Welcome back to For Your Health, where we dive into health issues into our communities that matter most. I am Dr. Rhonda-Marie-Chakolis-Hassan, and I'm your host. Today, here we are joined by Dr. Ida and Sam Simmons. We're going to be talking about the intersection of trauma, biology, and public health. Thank you both for being here. Dr. Ida, will you care to introduce yourself? And I think before we do that, I need to let everybody know that the views and opinions on this show belong to the individuals and don't represent the entities that we're affiliated with or work for. So, Dr. Ida, take us away. Tell us about yourself and how you got to Minnesota.
Thank you very much. As Dr. Ronda said, my name is Ida Tchuisseu Fonkoue. I'm an assistant professor in the Division of Physical Therapy, Department of Family Medicine and Community Health at the University of Minnesota. I moved here to start this position a little bit over 3.5 years ago now. My 4-year anniversary will be in September. Before that, I spent 4 years working at the Atlanta VA in Georgia, where I studied how post-traumatic stress disorder in post 9/11 veteran affected the physiology. So I am currently the director of the Neurobiology of Emotion, Sleep, and Trauma Lab, where I study young women. I'm looking at the same biological markers, but this time in young women.
Wonderful. And for people in our audience, Sam, can you briefly tell us about where you're from and how you got started in your work?
Yes, I'm Sam Simmons, and I am a behavioral consultant, and my focus is on Black male trauma and their families. And probably started this work about 35 years ago, actually starting with in mental health lock unit at the hospital, and then I worked in chronic pain for 20 years as well before starting doing primarily work in the community.
Wonderful. So both of you have elected to study trauma,
Yeah.
one from more of a biological and physiological approach, and then somebody who really is focusing on cognitive behavior. Can you tell the audience why you decided to get into this work? Dr. Ida, you go first.
Well, I hope I can give a very succinct answer to this question, but I have a personal connection to particularly the cardiovascular impact of trauma. Of course, I did not have this clear relationship in the past, but I knew that somehow I grew up with a younger sister who had sickle cell, who unfortunately passed away 2 years ago. And I think I saw my father go through, I was young, but I could really tell that each time my sister was sick, I could see something change in him. And I think it's because it almost felt like each time she was sick, he didn't know if she would be able to make it out of the hospital. And I think the worst event, because when it comes to post-traumatic stress disorder as a condition, it's very important to have that traumatic event. And I think the particular traumatic event I can remember was my sister being in a coma for three days. And my father he couldn't go home. He just went from the hospital to work and from work back to the hospital. If he made it home, maybe it was for a shower and change. And my mom avoided coming to the hospital because she didn't know if, almost as if she was waiting for the news of she's gone. So I was left being there in the middle, the person that, even though I had just started medical school, I was in first year medical school. But we all know the day you're admitted into medical school, you're already a doctor for your family. It doesn't matter if you've gone or not. So I was that person who was there during the day and at night, and with the person who was there to make sure communication with the nurses and my family was clear. And so I do believe that now, looking back, my father probably had an undiagnosed case of PTSD, as many people do. So moving into studying my PhD, and I've always been fascinated about the cardiovascular system, which is the heart and blood vessels and blood pressure, hypertension, and all of that. And so when I found out that there was this particular researcher who studied the connection between stress and the cardiovascular system. I thought this is really something I wanted to do. So after my PhD, looking at healthy individual put through stress, acute stress, and seeing how the heart and the blood vessel respond, I moved on to Atlanta to study a more chronic model of stress. Little did I know, by studying PTSD with a physician in Atlanta, that I'll go back down memory lane, thinking about even myself, what trauma could have done to my own health, and almost linking the trauma my father went through with my sister to the heart attack that finally took him away. So I have a personal connection to what I study. Yeah.
Sam, and then for the viewers who don't know, why did you choose to focus on a career that looks at combating trauma or addressing trauma?
Well, again, one of the reasons for that is I realized that wasn't a conversation that was happening in the community, right? You're exposed to all this different trauma. Then if we add historical trauma on top of that, right, and start connecting those dots, right, and having the trauma response show up in the community but not addressing it, uh, was a problem. But the other piece is that look, when you dig into addressing trauma, and when we finally was able to talk about trauma, which is interesting to me, is the conversation around trauma really got nationally big time when we start talking about ACEs, right? And I remember in terms of my early work around trauma, if you start talking about trauma and you're dealing with uh, uh, um, the basic organizations, when Black folks would talk about trauma or their pain, they would be told that you're making excuses. And then all of a sudden you end up with ACEs that prove that everybody got trauma, and particularly white folks got trauma, because, if you look at ACEs, the majority of the folks were, 70% of them were white, and a good 70% of them had some kind of college degree. Those are not the folks we think about when we start talking about trauma, right? And so now that conversation opened up more, and then the increased studies around the effects on us physically, emotionally, brain development, and all these other pieces became important. So how does that look culturally? When you throw that cultural piece and a historical piece, it's like, oh, now we got connecting the dots between the historical, the current trauma, and health outcomes for people of color, and particularly African Americans and folks with African background, right? And in that early death, of heart disease and those kind of pieces, even when we talk about trauma hormones around diabetes, right? And you look at the community, especially here in America, the two communities that have the highest diabetes is African American and Native American. What's unique about that? The trauma and the historical trauma. One was almost exterminated. A portion of our community was brought in the bottom of boats, and then we can go on to the continual trauma after that, and love connecting dots.
Right. Dr. Ida, so you really touched on a point. I think so often we've kind of said with these studies now, we know everybody has trauma. We think about it as emotional pain. I think what you shared your personal story, which is very touching, because I can understand, like, I'm a clinical pharmacist, and like you said, from day one, when you enter school, I became a pharmacist like as soon as I got that acceptance letter. But we so often don't talk about some of the physiological and biological things that happen when we experience things, like, for example, this whole fight or flight thing. Tell me some of the things that you know or that you've studied where trauma affects the body, and how does that look in people?
That's a very good question. So I stated earlier that I started with veterans at the Atlanta VA. And for those who know, the Atlanta VA is predominantly Black male. So some of the findings, original findings that we had with my working with my mentor at Emory was predominantly in black male. So what we saw is that post-traumatic stress disorder, and in this case, I now study what you call civilian, right? But in this case, this was really particular to veteran. We saw that PTSD, first of all, increased the fight or flight response that you talked about at rest. Now, you want to be able to fight or flee if there's danger, there's something you can really flee from. But if you have that activated fight or flight response when you're just sitting and doing nothing, that's not good for your cardiovascular health. Your blood vessels are being asked to do something they don't need to do at the time. What we also saw was that there was an increased low-grade inflammation. When we talk about inflammation, people could think about feet, heart, red inflammation is linked to temperature increase. So you can really take somebody's temperature and feel that there's some sort of fever happening. But this low-grade inflammation is almost like, although you're not feeling that fever, your cells are feeling it. Your cells are really under stress. And this, again, is not good because your cells are in a state of disease, although you don't have one of those conditions that are known to increase inflammation. And another thing we notice is that the ability we have what we call baroreceptors. These are receptors in our body that are able to sense changes in blood pressure and adjust. So we had reduced sensitivity of those receptors. That means that if your blood pressure goes up, and technically you should have a message going to your brain telling your brain, hey, it's time to press on the brake. It's like a car, you have the accelerator and the brake. But if you don't have this ability to sense that the car is going too fast and it's time to brake, well, what will happen to that car? You end up hitting something or being in the bush. So we have, and all of these are known risk factor for cardiovascular disease. So inability for your baroreceptors to be able to sense change in pressure and change it, increase inflammation at rest, increase fight or flight, and consequently decrease rest and digest. We talk about the fight or flight a lot, but there's the other system in the autonomic nervous system, the parasympathetic system, is your rest and digest. It's the one that should be active when you're resting. So there's a decrease in that system. So you see that imbalance that is happening. And in these young women, in this veteran Black men, we found all of these different risk factors for cardiovascular disease. Moving on to the population that I study now, young women. Now, young women are known to be protected from cardiovascular disease or heart disease. At least they were, because of this beautiful hormone called estrogen. Estrogen makes your blood vessels softer. Estrogen reduces the fight or flight. Estrogen reduces the inflammation. But what we're seeing in the young women that I study now, before menopause, is that it's almost as if estrogen is not doing what it's supposed to do. And in a subsample of a study that I published, we even see that there's lower level of estrogen in these young women with post-traumatic stress disorder. This opened another can of worm when you think about what estrogen does for reproduction and everything and being able to maintain a pregnancy up to term. So what we're seeing, and that is really concerning, is that in young women, it's almost as if PTSD is putting them in a state of early menopause.
Which makes sense. And I think when you connect some of these things, I see Sam's head nodding in terms of like, now I can connect some of these behavioral responses, right? A body that's in fight or flight might manifest itself as aggression or not resting or constantly on the go. Sam, are you able to make any additional connections, kind of like from what you've seen and how Dr. Ida is talking about, in particular in men?
Well, basically, it sounds like the bodies don't get turned off and get to relax, right? And you I'm thinking about what she's saying, and not having those flags pop up to let you know that about your that you're really on go all the time. That's really kind of, what the young folks will say, you're on go all the time, and our bodies are not set up for that. It's only set up for that elevated pieces in short spurts. But if you're always on go, when does that body or your body really get that rest and get to feel calm and those kind of pieces? And what's really throwing me, and I can see it more in behavioral when you talk about young women, right? In terms of the little bit more aggression and those kind of things externally, what we see more so than we have in the past, right? And so that's going on internally. Think about what's going on environmentally along with that, right? So
Dr. Ida, you made a great, this is all really good information because I think for so long we've thought some of these things, but we might not have had the biology or the evidence to really support this. I think it's very interesting that you went from studying veterans, right? Probably because it was tied to a fellowship or something like that, but you made a leap and decided to work with young women. What precipitated that change for you?
That's a good question. And I guess I get asked that a lot. One thing that I noticed when I was studying veteran is that we didn't have a greater percentage of women in the study. But for the women who were in the study, we had this questionnaire called combat exposure. And women had very low score in those combat exposure. Yet they were veteran, they were in the military, and the PTSD was supposedly associated to the fact they were veteran. So probing more, I found out that this PTSD in women in the military was not linked to combat exposure like men, but mostly to interpersonal trauma happening within the military. So, working with one of our, along the way, I had a new mentor who was one of the director of the Grady Trauma Project. The Grady Trauma Project is one of the largest civilian trauma projects we have in the U.S. It's located in Grady, and again, predominantly Black women. What I noticed is that whether women were in the military or outside of the military, they share that common interpersonal nature to their trauma. So I decided that it was time for me to study PTSD that has so long been linked to war. I really wanted to study PTSD in women in the civilian population. And I chose young women because, well, it was the population that I fit in, but also because I see and listening to Sam talk about the nurture part, the being a parent. Women bring children into the world. Think about it. A woman who have gone through trauma will now have to nurture a life for 9 months when they can't even take care of their own mental health and bring that child into the world and nurture that child. I feel like this is a population we really need to focus on. Otherwise, we're having a generation of children that are born and that are raised without the nurture piece they're supposed to have because the person who's supposed to nurture them does not know how to due to that trauma. So that's one of the reasons why I focus on this population.
I can see Sam just
no, I'm loving this.
I think the reason why I wanted to have you both here is I think a lot of times we'll do or we'll work on something,
Right.
and then you'll hear something from somebody else who has what we call antecedent evidence, right? But then all of a sudden you have the scientific evidence that really brings it home. Sam, I know in previous episodes we have talked about like what you've seen younger women be more aggressive, losing that nurturing piece. Is there anything you want to add to what Dr. Ida just said?
Well, see, the thing is I don't know if I mean, what you're saying just makes so much sense when I look at it. Did we ever nurture them? Right? I mean, especially in our community, we have this, we put this whole kind of responsibility on them to hold families together. even at the cost of their own bodies, their own situation. And what really struck me when she was talking about the question about combat with the women, but the first thing came to my mind, well, they're under combat in the community, right? And like, but again, just like we ignore black male trauma, we ignore things about women in general, but black women particularly, and unless they are more aggressive, they get ignored, right? And over time that became more. And I'm just thinking then with the external stuff in terms of that mental health stuff is, I often talk about the current population of young women then watch their mamas and their aunties do that struggle, elevate their partners when they didn't deserve to be elevated at the cost of themselves, to be responsible for somebody's manhood. And I hear them, it's like, Mr. Simmons, I ain't doing that, you know? And so, in their way of trying to combat that, they've taken on, again, she's talking about the internal, but the external taking on this aggressive mood. And the guys, they can't handle it. They can't handle it, But it's out of their trying to protect themselves, is out of, that piece about nurturing. It shows up in relationships when men impregnate women and then tell them up front initially it ain't theirs, until then they find out it's theirs. And basically once they find out it's theirs, now they want to be involved, but they're only focused on the child. And you'll see in some of the women I work with in their face, but what about me? What about me?
Yeah.
Who's gonna nurture me?
And Dr. Ida, what you're telling us, right, is from a public health perspective, and
Yeah.
we always talk about prevention and intervention. Using like the framework of your work, what strategies or what tools can we explore? What are you exploring even in the lab, as you move forward with this information that we have?
That's a good question. And anytime I have to say goodbye to a participant at the end of the study, because I see them 3 times for different measures, I feel like this voyeur, this person who had a moment into not only their mental health but their physical health, and now they're gone, and I have no way to help past that moment, and I feel almost powerless. So I hope that my hope with the work that I do and also talking about it is that this can hopefully inspire some policy changes, right? We now recognize sleep as a risk factor for cardiovascular disease. It wasn't the case 5 years ago. It wasn't the case 10 years ago. So if AHA can recognize, the American Heart Association can recognize sleep as one of the essential 8 for good cardiovascular health, perhaps a condition like post-traumatic stress disorder should be looked at more carefully. And it's only when those conditions like that are recognized as being really risk factor for a disease or something that that those public policies can follow. And we can now really recognize that having post-traumatic stress disorder should probably jumpstart more attention for this person, because it's not just in their head, right? It's biting their heart, their blood vessel, their emotion, their ability to just being who they're called to be.
Right.
In this case, for women, giving life, nurturing life, and living long enough to see that life prosper.
Yeah, well, I hear you talk about like a loss, and I think this show is just the beginning of many different things that you can do. Because even for me, these are things that I have felt for a long time. Like I can tell, like changes when I'm under stress. I can tell like what stress did to me when I was pregnant with my son, but I couldn't put my finger on it.
Yeah.
I think really just getting that message out to people to really say, yeah, no, this isn't in your head. And these are risk factors for cardiovascular conditions, which we know cardiovascular, diabetes,
Metabolic, yeah.
all of these things really play out because I think so often, even in healthcare, we just give them names like you just have metabolic syndrome instead of looking at, well, no, you have some experiences that have caused some remodeling in your
Yeah,
body, which has led to this metabolic condition.
yeah.
And then now, on top of it, you also have to add these medications instead of looking at really the
The root
root
cause.
cause. And so I think that's very powerful. Um, Sam, as we're talking about, and as I bring that back to you, now that you have this information that's really evidence based, what ways do you feel like this could be incorporated into the existing trauma work that you're doing with your men's group and even other practitioners?
Oh, I think it will go a long way. The big piece, we have to get systems to
Yeah,
really accept this, but we have to also break this down for uh the community to be
yeah,
able to talk about it. Because I think, when I first started this work around really focusing on trauma, it was difficult, right? There was a lot of pushback. Now you hear folks talking about trauma a lot more. Now they could probably do some improved ways, but at least we got people talking and also having them feel like they have some empowers them to know that there's some things they can do that doesn't take the system off the hook. Also, that old adage is, instead of what's wrong with you, look at what happened. And because of what happened, this is what it looks like, right? So that makes it a little bit more comfortable to talk about that because so often things have been presented for people of color, even women, and it always used to start out, what's wrong with you? And then when you start talking about what's wrong with folks often enough, they even back off and might not do what's best for their own behavior as well. And so putting that out, letting folks know that this is real, right? And you can have some agency. The more you understand, it's like the old adage: if you know better, you can do better.
yeah. And what you said earlier is one of my team member asked me, how do I know I have trauma? Or how do I know? I What you said earlier about being in a hospital, you go to the hospital and they're talking about cardiometabolic, and they're not talking about the metabolic syndrome, but they're not talking about the cause, the root cause of it. I think this is where practitioner and the healthcare come into place. When you go to the hospital, you don't have a diagnosis. You go to the hospital because you're not feeling well.
Right.
It's up to the person taking care of you, the practitioner, to trace back to potentially something that might have happened that you didn't address. And that's why care should be multi-approach care. It's not, you need to be able to work with other people in the care team, a psychologist, a psychiatrist that can put the finger on that root cause. The person itself just know what they're feeling. They don't know what is causing what they're feeling. They remember the trauma, but they don't connect the dot. So as much as we're educating the community, I think it's very important for healthcare provider to really stop avoiding and stop treating symptoms and really address the root cause.
Yeah, and so even just from a pharmacological and perspective, right? My eyes are being opened up when we think about different biomarkers that we test for. I think so often, and there was a Women's Health Initiative study that actually really did not do hormone replacement in women the service that they needed. Was said that it was bad. But thinking about what you're saying, it might be time for practitioners to even look at these biomarkers or estrogen levels when women are going through these traumatic events, and maybe even saying, hey, you know what? To get you out of this phase, to get you out of these things, we may need to supplement the estrogen
Yeah.
as a bump or whatever to get you through these challenges. And for me, that's kind of groundbreaking. I think so often when we look at men, if they come in with symptoms of depression or different things like that, people will automatically test for testosterone and then be like, well, maybe we'll just give you a little bump to get you through this. I think this is groundbreaking. It could potentially be used in women as well.
Yeah. So the findings that I published on estrogen right now is something new that the field is still trying to figure out how to grapple, because for a long time it was thought that perhaps it's not really the level of estrogen, it's mostly the sensitivity to that. So of course, as in anything, we need more research and more people to be able to confirm this potentially low level of estrogen that might be due to PTSD. And the more research is done on that and the more findings we have, perhaps that can go into that direction of what can we do now? What can be done?
Yeah, and you talked about sensitivities, and then we know
Yeah.
in terms of diet and what have you. Sam, is there anything that you like want to add on this, or you're sitting there, I can see like the light bulb coming on and some of the things that you're like, well, yeah, I've seen this.
Right.
I've seen the manifestations of this. Any culturally relevant practices that you can think about? Because I think about now when you're saying people go and they don't know what's wrong with them. What are some things that you can take away from this? Would you tell people now to do?
Well, the thing is, for me, is that this clarifies a lot of stuff that been exposed to, and because I do work with women sometime as well, and how do we again, you know, training folks, the systems, and changing that. But I think the other piece is how do we, the more our clients or the people know, the better they can advocate for themselves. Unfortunately, that's important that we have enough information to advocate for ourselves, to be listened, heard. Because I think, uh, folks of color in general, but and we break it down, different groups that have not been listened to, even when they do say, I feel this way, so that's the big piece for me, because I still have to absorb more of this and connect. I mean, it's connecting the dots in my mind, but to articulate it, out in uh, a way to, for other folks that we work with to, take it in and not feel bad about it, just understanding, right? Because the more you make folks feel bad about it, even though they know they need to deal with it, they might not, right? Because again, so often has been framed as something wrong with you and not looking at the environment. And I think sometimes systems don't, especially when we start getting into the more historical trauma piece, that makes systems uncomfortable, because they start taking it personally, and that it is like I always have to tell them, it ain't about you. It's about understanding so you don't continue to do this. So
Yeah, and so what I'm hearing from the two of you is so often, like, I think about even when we're talking to students, right? You talk about um, these things that we experience where we're like, oh, I don't belong here, or I have this feeling. It sounds like what we need to do is approach trauma from two standpoints, right? One, there certainly is the cognitive issues. Of course, there's a thing in terms of medication. I know a lot of women who've experienced trauma, the first thing they do is they go in and they're handed, okay, here's some hydroxyzine and here's a SSRI. You can take some Lexapro, citalopram, and here you go. Instead of saying, hey, this is a time that you're going to want to work on mindfulness and learn how to work with your breathing. This is a time that you like to eat certain things. This might not be the time to do that. This is the time that you might want to think about your cardiovascular health. Anything you want to add to some of that? And
I like the fact that you say we medicate, and as a believer of Jesus Christ, I know the truth shall set you free. And I think sometimes instead of medicating, we need to give an opportunity to people to actually talk and just be listened to. Not just, as Sam said, not feel guilty about what happened to them, but talk about it. Let's share the light on some of these things. And this is kind of why this is important. Let's not make it a stigma anymore, because it happened to you.
Right.
The more we share the light on it, the less people actually might need. Perhaps they will need medication to help with nightmare until it can go away. But this talk therapy is very important. And it's not necessarily, it can happen in the community. Community is one of the first element of resilience, right? Being able to have a community, whether it's a family, church, neighborhood, coaches, whatever, a community where you can be felt, heard, and seen, and you can really talk. We cover a lot of things, and that end up hurting more. Information, education, and communication is something that I'm passionate about, because I feel like if you can be your sister, your mother, your daughter's keeper, and your brother's keeper, that is really important. Because if I notice something, even if that person can put a word on it, I care enough about them to be the one trying to find out what's going on, or taking them to seek care, because I'm noticing things. I'm informed about things, and I can see something is going on here. And talking about ACEs, which is adverse childhood event, if we start paying attention, perhaps we can catch things for our children early on, so that when they go to that period of adolescence, where your brain is like a blackboard where you can wipe and erase things and write new ones, perhaps during that phase we can really wipe certain negative things and start writing positive things, so that they don't get into adulthood with leftover trauma. Because studies shown that when you have been exposed to trauma young in your life, that increases your risk of compounded trauma for many reasons. Not seeing your worth, and putting yourself in more dangerous environment, or to just not having boundaries, and allowing certain things that you shouldn't allow. So
Exactly.
Yeah, Sam, anything you care to add on that?
No, I mean, we can end on her statement. She covered it.
Okay, which the people who know you on this show, is the fact that you have so little to say that tells us we have a lot to dive into.
yeah.
Dr. Ida, I really also thank you for sharing your faith. I had a wonderful conversation with Pastor Land, who is a minister in St. Paul, and he has done a lot of work, and he's written books. And at some point, we'll probably have to have him on here and talk about his books in terms of healing using the Bible, using whatever. But we had a very interesting conversation at breakfast a few weeks ago, and it's something that has really stuck with me for the last few weeks. Is do we see, or do I see, an increase in mental health problems? And I said, yes. And he was like, well, I want you to think about why. And when we started talking, I said, even though we're very connected through the internet and social media and all of these things, sometimes for me it appears that we're more disconnected than ever.
As well.
uh, we've lost like our sense of community. We've lost our sense of belonging to church. We've lost our sense of vulnerability, because kind of going to something that Sam always talks about is feeling safe. I think in talking to both of you, it's really an opportunity to say, how do we go back to some of these things? Everything that's groundbreaking isn't necessarily the best, but there's evidence from thousands of years that says being able to be vulnerable with community, having a church, having a safe space to even talk about these issues, because again, we operate from, oh, I don't want people to know I've gone through things, or I got to do it for the gram, the young people say, if that's what they're even doing, or on Snapchat. What are some of the things that you think your research can be used to help the public kind of improve their health overall?
Um, my first language is French. So there's something in French that say, my people died because of lack of knowledge. So I hope one thing my research can achieve is really knowledge, really sharing knowledge and arming people with knowledge. What they do with that knowledge will come slowly, but being able to arm people with knowledge, again, going back to it's not all in your head. Somebody can tell you, yo, we're strong, we're supposed to be resilient, we've gone through more than this. Yes. What is our life expectancy because of all those things we've gone through? Why don't we live longer as other people do? Why do we have all these chronic diseases? Perhaps it's time to really talk about the fact that you may think you're resilient in your head, but the body is keeping a score. So I really hope my research can be that knowledge that hopefully arms people.
Wonderful. And Sam always talks about resilience, right? It's a word that we throw out. But again, I go back to something that Sam has said so often, right? About our suffering narrative. It seems like maybe there's an opportunity to really give people an opportunity to talk about that suffering narrative. I think Sam's been really good about that, but just saying this is a space where you can do that because a lot of times when I've been at conferences, it's like, yep, we know this, but we even trivialize that. Even when I think about students when they come to me about imposter syndrome, right? We throw this word around. I always encourage them to say, well, what does that look like for you?
Right.
Because imposter syndrome for me was I didn't really talk until I was 30. Now, you don't know that now, but I didn't talk at all. I just sat there and I observed. So imposter syndrome for me sometimes is like, do I even belong talking? Um, so Sam, anything you want to add to that or kind of as you're taking that in?
Well, not a lot. I mean, the thing is that when again you bring up the issue around resilience and we have to look at what that means for each of us. A young man I had in my group was talking to his grandmother, and his grandmother wanted to know where was he going every Tuesday at 6 o'clock. And because he wasn't him doing something regularly at 6 o'clock was unusual for him. And she said, "Baby, where you going every Tuesday at 6 o'clock?" He said, "I'm going to Mr. Sam's group." But what do they do in Mr. Sam's group? They talk about trauma. And Grandma said, "Oh, you go back and tell him that we're resilient people and quit being negative." Okay, that was early in the process. And he came back and told me, and I said, "Well, tell your grandma, thank you, because I ain't gonna go against grandma."
Mm-hmm.
I said, "But what do you think she meant by resilience?" And he paused. He thought about it. He says, "We're like roaches. We ain't going nowhere." Okay. And he was serious about that. Because other guys, they were in the group. "Yeah, what you think about that, Mr. Simmons?" I said, "Oh, no, just think about what you just said. Resilience got to be something deeper than that, right? And so how do we learn how to thrive in the midst of this resilience, right? And, more than just, return back to where we were before the trauma. But if you've experienced trauma generationally, what are you going back to? So we're really about how do we teach new skills without shaming people is the big piece. Because there's a lot of shame we carry because of other people's narratives, right? And which gets in the way of us taking care of ourselves. And so the more information we have and the more we let folks know it's not about what's wrong with you, it's about what happened to you and looking at how you can find a way not to continue to participate in what's happening to you as well.
Yeah, Dr. Ida, as we talk about it, and I know we kind of briefly touched on, you have all of these accolades. You're a double doctor, right? You're a medical doctor, you have a PhD, you've done research at internationally institutions, but yet your faith your love for family and your love for people keep you going and grounded. What are some of your next steps in terms of like where you're at with your work? So usually when we do research, we have a certain amount of time. Um, I know there's issues with everybody right now on potential funding and what
Yeah,
have you. But again, I think when we look at research, it's like, what is the purpose and what
yeah,
is the value add? It seems like to me, your research is a value add that we haven't heard and we haven't had the evidence for. And then I'm thinking of a health plan, right? I don't want that doctor just to put you on a blood pressure medicine. I want them to get you some cognitive issues and figure out if you have PTSD. Because if I don't, you're going to cost me more money
mm.
to insure you. And then, the cycle goes on. But tell me what are some of your next steps?
So thank you for that question. This is kind of part of my next step too. Being able to be here on this stage and start talking, getting what I call breaking down the walls of the lab, um, and being able to get into the community and being able to share what we find, because the people who actually need to hear this do not read all the journal paper that we publish all the time. So this is one of my next step. The other next step is really to be able to, okay, I've seen all of this. Now, what can we do? I'm very interested in non-pharmacological approaches. Like, what can we do, whether it's meditation, music, nutrition? What are the ways that we can deal with the symptoms of PTSD? Now, there's something about PTSD. Once you had it once, you can have current PTSD or lifetime PTSD. So lifetime means you've had it at some point. It's not like, okay, you heal and you don't. But the symptoms can be kept at bay. A little bit with HIV, people have the CD4 at a good level, the viral load is low, but they're still having HIV. You never totally heal from it.
Mm-hmm.
But what can we do to keep those symptoms at bay so that you can live a good and fulfilling life, right? So I'm looking at those non-pharmacological interventions. And, but like I said earlier, the key is still, I don't know where life will take me. And you talked about funding earlier. But no matter what happened in the future with funding, I see myself really continuing in this road of sharing, informing, educating people. Because what you touched on something earlier. When I was doing my postdoc at Emory, around the time George Floyd was killed, I had a lot of anxiety, very high anxiety. My blood pressure was really high. So I went to see my primary physician. And because we had this relationship where we just talked, he knew that I understood everything because, I was a medical doctor as well. So we had conversation. So he gave me a prescription on a paper. He said, first of all, I'm not going to give you any medication for hypertension because I don't think that's the problem.
Mm-hmm.
He could have just put me straight on medication. You're having 150 over 90. Let's treat you. No, he said, I'm not going to put you on medication because I think the root cause is the anxiety. Let's talk about how we can address that.
Mm-hmm.
Should I give you a prescription, and when you feel like it, you go and fill that prescription and then start taking it? Should I send you to someone that you can talk to? And I'm still grateful to that physician today because just as he predicted, once I was able to deal with anxiety through my faith, through talking to someone and occasionally taking a medication, my blood pressure went back down to normal. So this information is important. We need people to be informed, but we also need practitioners to not just medicate, to listen and ask questions. I know it's hard to do with 20 minutes. Is it 20 minutes or 10 minutes?
Depends on what kind of visit it is that you're being coded for. So yeah.
Yeah.
I mean, that part is important, but kind of closing out, I think you bring up something very important. If we look at the HIV model, we have now been able to achieve what they call undetectable viral loads through two mechanisms: pre-exposure prophylaxis and post-exposure prophylaxis. If sounds like there's an opportunity to use that same framework for trauma.
Yeah.
How do we
Yes.
tell people, instead of, so often Sam has talked about, like, I'm gonna beat you so they don't kill you. How do we take that mindset and say, hey, you may be exposed to these things, but when you are, here's some strategies, here's some things. And at the same time, let me listen to hear what's there. And then when we look at post exposure, yes, you've had this. There might be some physiological things, but looking at it from that framework. As we close out this episode, Sam, is there anything that you want to add or like to share?
No, I'm good. I'm listening to the expert. I didn't. Actually, at this point, there's nothing else I could add to what how she finishing up.
Yeah. And I think from what I'm seeing and just working with you, it's like, that's what I was looking for all along.
Right.
This validates the work that I'm doing. This validates my experience. Dr. Ida, I know you are currently doing research. I'm not sure if this is an opportunity that you want to share this information. If people want to look that up, they certainly can, but there's an opportunity for us to have links and post that at the, as we run this episode. Are there any final words that you would like to share with our viewers here?
I would share my information for the lab, but before I would really want to say thank you and for this opportunity, and also thank you for wrapping it so well with the HIV model that you just gave. I think we can learn from what we've done before. We don't necessarily have to reinvent the wheel for different, just like some medication are adapted for new conditions, right?
Right.
So I think you did such a great job finding similarity between what we did for HIV and what we can do for trauma. So thank you. And I'm so happy to be here with you. I learned a lot. It was fun. And I feel really humbled and I feel like I'm being nurtured right now. So I appreciate that. My lab is called the Neurobiology of Emotion, Sleep, and Trauma Lab. The abbreviation is NEST, which kind of really what a nest should be. And when that acronym came together, I was so happy. So it's called the Nest Lab. So anybody who look up my name, Ida-Tchuisseu Fonkoue, University of Minnesota, the profile comes up and the link for my lab is there. And on the link to the lab is how to participate. If anybody wants to participate or reach out for anything and want to come visit the lab,
I think I'm gonna come
yeah,
visit the
yes,
lab. It
come
sounds like
come visit the lab. I
right.
heard about a group who would like to bring some students to visit the lab. I did that as a graduate student. I brought middle schoolers to the lab to show them certain things. And so, yeah.
I just want to say you both are remarkable. I feel very fortunate to be here, and I think there's so many things that can come out of this. One is making sure that we use our networks to provide you an opportunity to share this information with the community. But the other thing that I like, that you're very open to, is opening your doors so that people can come and see what it's like and know that it is a possibility for you to transcend all of the things that you even talked about with your own family,
Oh, yes. Yeah.
and still be here in a space, walking in your purpose, being grounded in your faith, and then still having science, which is something we often are not taught that we can do. So I thank you both for being here. I look
Thank you.
forward to future opportunities to
Me
talking to
too.
you both. And my name is Dr. Rhonda Marie Chakolis-Hassan, and this has been For Your Health.